So in terms of advances in treatment, I think there's really three areas I wanted to focus on as we finish up. The first is the use of bevacizumab. The second is Parp inhibitor use, particularly after initial chemotherapy, and immunotherapy. Avastin is commonly used. It's actually FDA approved in all settings for ovarian cancer with initial chemotherapy, with chemotherapy for recurrent platinum-sensitive disease, with chemotherapy for recurrent platinum-resistant disease, and as a single agent. The way it works is it binds to a circulating growth factor called vascular endothelial growth factor, or VEGF, and it prevents VEGF from going to the receptor and stimulating new blood vessel formation. And we know that when new blood vessel formation is blocked, that tumors can't grow. This seems to be particularly helpful in patients who have a lot of fluid accumulation, ascites on the abdomen or sometimes around the lung as part of their disease process. The Parp inhibitors, there's 3 that are FDA approved for ovarian cancer. These are most commonly used for patients with the BRCA-associated ovarian cancers, but the new news in the last 6 months has been using them as maintenance after initial chemotherapy in patients who respond to their initial platinum and taxane therapy can benefit some patients. So we'll go through the data for that, and then we'll finish up talking a little bit about immunotherapy. So GOG 218 was a large trial done in the United States that looked at adding bevacizumab. You can see in the first arm here that paclitaxel carboplatin was given with placebo followed by placebo. That's the standard arm. Paclitaxel carboplatin with bevacizumab followed by placebo, so only giving the bevacizumab with chemo. And then the third arm gave the bevacizumab with chemo and used it as maintenance afterward. And the important thing in this graph is that the benefits really were in the patients who got the bevacizumab with chemotherapy and afterward, that there really wasn't much of a difference in patients who got bevacizumab with chemotherapy but didn't get it afterward. And because of that, we all wish there had been a fourth arm here that was chemotherapy with placebo and then bevacizumab afterward, but unfortunately we don't have that. Long-term follow-up of this has shown that there are really no huge differences in overall survival. The most recent publication looked at a whole bunch of different groups, and the main thing I wanted to show you from this is that the overall group and then some different specific subgroups really didn't seem to have a difference in their survival. The one group that seemed to have a little bit of a difference here is patients with stage 4 disease, and they may really get a little bit more of a benefit from bevacizumab. So bevacizumab can be used with initial chemotherapy. It doesn't have to be. I think it's used a lot more in Europe than it is in the United States. It certainly is something that is considered in some patients. Now, these are slides. This is a complicated group of slides, but these are looking at the use of bevacizumab and mostly afterward, but in some of these with initial chemotherapy for ovarian cancer. The first slide is Solo 1, and this is data specifically in people who had a BRCA mutation, a germline mutation or mutation in their tumor, and these data have been out for a while, and you can see very significant differences in the progression-free survival in patients in this who got the olaparib Parp inhibitor, which is on the upper arm. In 2 of the other studies, Prima and Paola, these are data from the BRCA mutated groups, and you can see that there's still a benefit. There's maintained a benefit for patients with the BRCA mutation who got the Parp inhibitor. In Prima, they was using a different Parp inhibitor, not olaparib but niraparib, and Paola was using olaparib with bevacizumab. The Valia study used veliparib, which is not an FDA-approved Parp inhibitor, and using it with chemotherapy and afterward, and again, in the BRCA mutated group, does show a benefit here. So across all these studies, very clear benefit for the use of Parp inhibitors largely after initial chemotherapy for ovarian cancer. And you remember from our little doll figures that that's about 25% of patients, about 15% who have a germline mutation, and about another 10% who have tumor mutations. One of the questions that comes up is about whether we should be doing tumor mutation studies, and we now think that you should have that done before you finish initial chemotherapy to know whether you're a BRCA mutation carrier and whether you get these really big benefits from the addition of a Parp inhibitor. In patients who have a BRCA wild type, you can see these curves are not nearly as separate. So there can be a little bit of a benefit with this, but not nearly as much. There are other tests that can be done in the tumor for that HRD that we talked about, the homologous recombination testing. And if we look at patients who have BRCA wild type but are HR deficient, they get a little bit more benefit here. You can see those curves are a little bit more separate. They're not as separate, though, as the BRCA mutation carriers. And so the patients who are in those 5 of our doll stick figures on the right in gray who don't have HRD and who don't have a BRCA mutation, what you can see is that the differences in using a Parp inhibitor are much smaller in that group of patients. And it's really only in the PRIMA study where there was a significant difference, and that difference was small. It went, the recurrence time went from 5.4 months to 8.1 months, so less than 3 months for the addition of a Parp inhibitor. So this is a slide from my friend Joyce Liu looking at the different scenarios, and we've been talking about initial chemotherapy, but it also in the recurrent setting where there's a benefit for Parp inhibitors. And this is going over like lots and lots of data that we don't have time for today. But I think that potentially more important is this slide, which says, what are some of the areas where we don't have information? So if we look at this last column on the right, other molecular phenotypes, almost all of these studies were done in high-grade serous. What about others? What about clear cell, endometrioid, mucinous? Do they get the same kind of benefits? What about patients who have germline mutations in other genes? Do they get a benefit? And then if we look at the rows down here, what about people who previously had a Parp inhibitor? If you had a Parp inhibitor before, you've been off it for a while, and you have a recurrence, are you going to benefit from that? And can we use combinations of Parp inhibitors and other treatments that might improve outcomes for patients? And these are all areas of active research. Just to comment on that HRD testing, this is a test that's done by Myriad Genetics that looks at 3 things in the tumor, and they have a calculus that gives you a score. In some of the studies that were done, they used this score of 42. In others, they used a different score. This loss of heterozygosity can be reported and is reported by lots of other testing companies, and maybe the loss of heterozygosity or LOH may be just as good as looking at all 3 of these. Immunotherapy is not standard for ovarian cancer. Pembrolizumab is an option for patients who have recurrent microsatellite instability high or mismatch repair solid tumors. And one of the early questions we got, I think even before we started, was about somebody who has an MSH mutation in their tumor. And those patients usually have mismatch repair deficient. And there is an FDA approval of pembrolizumab for people with any disease that is MSI high or is deficient in MMR, and a very small fraction of ovarian cancers will have that. There is no immunotherapy, though, specifically approved for ovarian cancer. And this is just, I wanted to show you this. Many of these drugs on the right-hand side, you guys have probably seen things on commercials on television about these. There are many of these that are being looked at as part of clinical trials for ovarian cancer, and they're targeting a bunch of different things that are interactions between the tumor cells and the immune cells to try and cut down on the immune suppression and activate the immune system to fight the tumor. And that's really the goal. I will say, however, that if we look at the data in ovarian cancer, the overall response rate here in the second column down to a variety of treatments has been kind of disappointing, ranging from 6% maybe up to 22% in a very small study. But these have not been very exciting response rates in ovarian cancer. If we also look at things that are markers of response to immune therapy in other diseases, PD-L1 expression is one, and what you can see here is the different types of ovarian cancer. The PD-L1 expression is actually pretty low across ovarian cancers. Microsatellite instability we talked about. The good news for those of us who do GYN cancers is that first column over there on the left is endometrial cancer, and that has the highest rate of microsatellite instability and therefore potentially allowing treatment with immunotherapy of any cancer. If we look down here, though, at the big blue arrow, this is the rate of microsatellite instability, and it's only 1 to 2% in ovarian cancer. And so if you are one of that 1 to 2% and you have microsatellite instability, that can come from Lynch syndrome or it can be part of the tumor. But that very small fraction of ovarian cancer patients it's reasonable for us to use immunotherapy. summary, I think, for immune checkpoint inhibition, there's low levels of biomarkers of response to immune checkpoint inhibitor in ovarian cancer, and probably if we're going to find something that works, it's going to be combination with other immune checkpoint inhibitors, combination with cancer vaccines, or with adoptive therapy like adoptive T-cell therapy. So I know there's a number of questions, but hopefully we can hold those till the end, and I'll hand this over to Amy for clinical trials.